Good afternoon, everyone, and welcome. I'd like to acknowledge the local custodians of the land in which we're meeting on and honour elders past, present and emerging. I'm sitting on Dark and Jungle land today, beautiful Voca Beach. Welcome today to the Mastermind. Thank you all for being here. Hope you're all staying safe and well out there with the weather's been terrible, basically. So I hope you're all well and safe and going okay. I'll just go through some housekeeping. Just a reminder to please remain on mute. Any questions that you have, we strongly encourage you to ask them and pop them into the questions or chat box. If we don't get to all the questions, we will follow up with those after the event as well. Today's being recorded and will be available in our education library for your reference with a copy of the presentation. We will be having a little QR code today as well. So have your phones ready, or you'll be able to also access this after the event in the education library. It's also been emailed out to everybody as well. The survey will pop up as always at the end, so we strongly encourage you to please complete that. That gives us feedback so that we can access further events and make them really relevant for you. Okay, without much more ado now, I'm going to introduce our speakers. So we've got Claire Sheekey from Kidney Health Australia. Welcome, Claire. Thank you for being here today. Really appreciate it. And to Deborah Wilgansky, who's one of our PCIOs at the PHN, and her subject specialist is in kidney health. So welcome, Deb, as well. Thank you both for being here. I'm going to hand over now to Claire to kick off the event. Hope you enjoy, everyone. Bye.
Hi everybody, welcome to this event. Thank you for the invitation to join. I just have a little welcome couple slides. If you didn't know, this week is Kidney Health Week, and this week we've been really pushing out in a digital sense, mainly because of COVID, but the first thing we've done is hold some digital webinars. One was held today at lunchtime, just prior to this one, but they've all been themed around the Kidney Health Week theme of Kidney Health for All, which is, I think, a really great focus for Kidney Health Week. Usually it's around awareness or a particular focus, but this encompasses everybody, from people that need to know about kidney health and those with suffering with kidney disease. It actually covers all of that. So we've been really impressed with the attendance to the webinars. We've had one on nutrition, movement, sleep, and today was about stress and also our peer support and our buddy program. Those are all being recorded and are on our website available for viewing. They only go for half an hour, so really good little bits of information to have a look at and also offer to your patients that you might have. The other thing we'd like to offer all the attendees today is 20% off our really handy book that I sit with me at my desk. It's our management handbook guidelines. It's the 4th edition, usually $15. So we're offering participants 20% today. So I'm online to answer any questions and hand over to you, Deb. Thanks.
Great, thanks so much, Claire. So today we're just going to go over some quality improvement activities and then focusing on risk factors for chronic kidney disease, the kidney health check, the diagnosis, staging, clinical action plans, and monitoring and management. There's a couple of statistics that I'll start off with. So this is the Australian Institute of Health and Welfare. This is the PHN list of the first slide is about CKD prevalence and under New England Central Coast boundaries. We are 4th worst for prevalence. The middle slide is about hospitalization, and we're 3rd worst out of 31 PHNs, the boundaries, and then the death rate, we're 2nd worst. So a little bit of work to do on that. This one is about New South Wales LGAs in particular, and the dark blue colouring is the highest rate per 100,000 of population. The all LGA rate is 56.5, but you can see that Cessnock, Gunnedah, Moree, Plains and Tamworth are well above the all New South Wales LGA rate. So that's quite specific data up to 2018. I just wanted to head you over to our PHN website. So this is the primary care support page. It's under the programs banner there. There's a chronic kidney disease tile that you can click on. Alternatively, you can use the thread on the left to get into chronic kidney disease. And then once you're in there, you can see lots of resources about data and dashboards, quality improvement activities, resources for the patient, our community of practice for health professionals, and then resources where you find a lot of the Kidney Health Australia resources that Claire was speaking of. If you need to contact me about this site, that's my email address there. So that's a great resource for you. So the first quality improvement tool that we have at the PHN is called the General Practice Summary. And I've circled the chronic renal failure there on the left under disease prevalence. And I know that it's now called chronic kidney disease, so we'll be amending that. But you can see that this particular practice has 135 patients that are coded with CKD. But also you can see that there's 369 patients that are not coded with CKD, but CAT4 that you may have in your practice is indicating that they've got some pathology that the patient should probably be reviewed and so that they can get a coded diagnosis. So we have some other things there. So diabetes, as you know, is a comorbidity with chronic kidney disease and also cardiovascular disease. So those prevalence rates are there. Ethnicity, we know that Aboriginal and Torres Strait Islander persons are more at risk. There is an area there where we show ethnicity not recorded in the practice. So that, for example, in this practice, 157 patients don't have their ethnicity recorded. So that's a good risk factor to be able to run kidney health check. Also, lifestyle risks. So weight, we know is associated, and so you can see this practice has 1,400 persons that are obese and 1,800 whose weight is, BMI is not recorded. And similarly, you can see the smoking risk factor, current smokers and persons whose smoking status is not recorded. And then the last one there is about the health assessment for Aboriginal and Torres Strait Islander people, the MBS item 715. And you can see there that of the persons that did have ethnicity recorded, 132 have not had a health assessment. So that can be quite useful to screen for risk. So what we have done is built 4 quarters of quality improvement activity focused on chronic kidney disease. So they kind of are chronological. So you look for patients at risk, look for patients that are uncoded in the practice, provides the chronic disease management items, and then look at chronic kidney disease clinical action plans. So we reckon that that would be a nice 12-month quality improvement strategy that would help you to meet the QI-PIP, incentive payments, and also accreditation. That can be good evidence for that. We also provide a plan, do, study, act cycle where you can think about the activities that you want to attempt and then also review how you went with that activity, study the baseline results, and make any changes to your activity and reapply it. The other item I wanted to suggest was the Lumos program. And so this is a data matching program between New South Wales Health and the PHN and general practices. It is de-identified, but in regards to hospital admissions, there's a nice line there about chronic kidney disease as the main diagnosis at hospital. And this compares it to this PHN, so all practices in this PHN, and then also all 10 or 11 PHNs across New South Wales. So you can get a real feel for hospital admissions of patients with chronic kidney disease in your practice. So just in regards to risk factors, this is from the Kidney Health Australia handbook that Claire was speaking of. So there's a lovely diagram there about risk factors. So what we've done is we've partnered that with the CAT4 recipe in the system in your practice, which is the CKD at risk report. And that forms quality improvement activity number 1. So it's all tied really nicely together with evidence-based practice, data in your practice, and then a quality improvement activity. So in CAT4, for that CKD at risk report, you need to just press on the report tab for CKD and then the CKD at risk sub-report. And so what it will show you for patients that are over 15 that don't have a CKD diagnosis already, but they do have at least one risk factor. So it will show you these patients in red that have this risk factor. So you would be able to click on that bar chart and re-identify those patients so that you could ask them to reattend, so that you could run a kidney health check based on the fact that they've got these risk factors but they've not been diagnosed. So the kidney health check, again from the handbook, so we know that 90% of kidney function can be lost before symptoms are present, so that's why annual checking is really important. And also these persons, they may not have any symptoms until they reach stage 5 for dialysis. So the kidney health check, this is a beautiful graphic from Kidney Health Australia, a blood test, a urine test, and a blood pressure check. So the indications are those risk factors that we spoke about. The frequency is every 1 to 2 years. So the 1 year is annually for patients that already have diabetes or hypertension. Oh, yep, sorry, there we go. So for Aboriginal and Torres Strait Islander persons, I just wanted to put this up, that for persons aged between 18 and 29, it's a screening for the risk factors. And that's really important for doing that during the annual health assessment that I spoke of earlier. And so that comes about because you've identified ethnicity. And so it becomes a nice package of identifying Aboriginality and then doing a health assessment and incorporating screening for risk factors in that. However, for persons over 30 or for these 18 to 29-year-olds that do have a risk factor, you would do a kidney health check. So that's every 2 years or as indicated if the cardiovascular risk is elevated. So this is the algorithm in the handbook. So again, it's about those risk factors, doing that blood test and that urine test, and then interpreting those results. If you do have that reduced EGFR or you do have that elevated ACR, then actually you do need to run 3 collections in the 3 months, greater than equal to 3 months to be diagnostic. So yes, so diagnosing CKD. So there's a lovely diagram here that CKD is defined as estimated or measured EGFR less than 60, present for greater than equal to 3 months, and that's with or without evidence of kidney damage. Or it could be evidence of kidney damage evidenced by the following, such as albuminuria, hematuria, structural abnormalities or pathological abnormalities. So the EGFR, the ACR, and then determining why the underlying pathology is there, that all leads to the CKD diagnosis. So CKD in itself is not the primary diagnosis, and so attempts should be made to identify the underlying cause. So we've partnered that with the CAT4 report, which is indicated CKD and not diagnosed yet, and that's the quality improvement activity that goes along with it. So this is a nice chart in the handbook that kind of makes it clear that kidney damage in the albuminuria stage or the green box that talks about other reasons for kidney damage. Or you can have the kidney function stage, which is about loss of kidney function. But you can see that it then gets stratified into yellow, orange, or red. And I'll show you about those clinical action plans in a tick. So what it needs to happen is they need to be partnered together to arrive at a full CKD diagnosis. So combining the EGFR stage of 1 to 5 with the albuminuria stage and the underlying diagnosis to fully specify, for example, stage 2 CKD with microalbuminuria due to diabetic kidney disease. So that's a full diagnosis there. So with the data cleansing, I wanted to show you in CAT4. So you would go to the data cleansing tab, and then you would go to the indicated CKD with no diagnosis sub-tab. Then just navigating in this report, because it can be, there's lots of stuff here to play with. So you can sort the columns from top to bottom so that you can get the results in order. You can double click on a patient and open it in your clinical system. So it does come up with the CKD stage that CAT4 reckons that it is. But just to note that that's only using the most recent EGFR and ACR, and you remember that the diagnosis is about 3 results, greater than equal to 3 months. So you do obviously need to review the patient. And just to note that sometimes the pathology can be corrupted. It can drop in to the system with an EGFR of 0 or no ACR result. And so these ones, the stage doesn't have a color or it doesn't have a number. So some of the other things in there are the BSL and the fasting blood glucose, smoking status, diabetes diagnosis, hypertension diagnosis, obesity diagnosis, cardiovascular diagnosis, and then indigenous and aged over 30. And that can just help to inform your review. If you find that this person doesn't have chronic kidney disease, you can tick the box on the right, which is confirmed condition does not exist. And then you would save and remove that from the list, but they would always appear under the reviewed sub-report. You can always see them again. And also just to note that when new pathology drops in, they will reappear on the list. So this is about the clinical action plans in the handbook. So they're color-coded, you know, yellow, orange, red. But it's nice to note that they're cumulative. So you can see there I've circled the plus. So, you know, the yellow action plan, you'd always do that, but you might add in the orange action plan depending on their pathology. And remember, we looked at the color coding of the chart. And then these have different review periods. So the yellow one is at once every 12 months, the orange plan is every 3 to 6 months, and the red action plan is every 1 to 3 months. So there is a nice CAT4 report about management, and a lot of the terms in the clinical action plans are in the CAT4 bar graph report. And so we partnered that with quality improvement activity number 4. So I just wanted to go over the CAT4 report there. So just keeping in mind the target population is over 15 and they have a CKD diagnosis, but they're not on dialysis or not on transplant. So things to look out for are blood pressure, body mass index, HbA1c, LDL, total cholesterol, smoking status, medications, and including statins. So the coding, the legend there is that dark green is recorded as prescribed. The light green one is about whether they're at target, which is really handy to be able to use these bar charts and perhaps focus on the yellow area where they're not at target, or, well, in particular, the red area where that management item is not recorded. So you'd be able to re-identify the patients in your practice by clicking on the areas of the chart. So this is a nice quick reference guide from Kidney Health Australia and Penn CS together. So it does talk about the definitions of the management items and the timeframes, and also the at-risk items, and then what the detail is about that. So that's very handy, that quick reference guide. So one of the things I just wanted to point out is across all of the action plans, the yellow, orange, and the red, it does talk about a whole of practice approach to CKD. And so I just wanted to mention that, you know, there's a lot of issues that can be common problems with a person with CKD. And so you might be using a GP management plan, you might be using the nurse chronic disease monitoring item number, the 10997. You might be making a team care arrangement. You may be reviewing the GPMP and the team care arrangements. You could be doing medication reviews with your pharmacist relationship, case conferencing, mental health care plans, specialist referrals, obviously. So through psychology, psychiatry, dietitian, dermatology, respiratory physician, pharmacist, and obviously nephrologist. So we've put together this last activity, which is about chronic disease management, and that will just help you with CAP for finding who does and who doesn't have GP management plans and team care arrangements. So that is the end of what I was going to present. So we've talked a little bit about the health statistics in the Hunter New England Central Coast Primary Health Network boundaries, and also the LGAs of concern. So we looked a little bit at quality improvement, the tools that we have, the dashboard that we provide each quarter, model for improvement, and the PDSA cycles. And then we looked at the risk factors for chronic kidney disease and performing the kidney health check. We looked at diagnosis, definitions of that, staging of kidney disease, and then we looked at clinical action plans and the monitoring and management of those. So, are there any questions? Any comments?
Yes, Deb, I'm just going to read out a couple that have been submitted prior. So we'll start off with those. And if anyone else has any other questions, please pop them in the question box now for us. So patients don't often complete the 3 required urine collections for CKD diagnosis. How can we ensure that this is done?
Claire, did you have any ideas?
I think that's one of the difficulties with the diagnosis and completing the kidney health check. It really is about developing up a practice system to capture those people. I also think it's the awareness with the patient of why they're having to do those tests, why it's important to have the repeat. I've already done this, why am I doing this? So it's really getting that education down with the patient. And Kidney Health Australia are working this year in particular on a particular project to give GPs and practices some tools to improve on the detection and management of chronic kidney disease, and that we're developing some how-to guides, and one of those is how to, you know, convince your patients that they need these multiple tests. So we do recognise that it is a barrier, but it is about, yeah, having that conversation and having those systems in your practice.
Claire, do you think it would be handy, like for example, when a patient gets a pathology request form, that they're provided with the urine pot? Because, you know, like I understand it's meant to be the first morning void that more accurately reflects albuminuria. And I know from myself, if I go to a pathology collection and perhaps I've already weed before I've driven, or I'm dry or something, perhaps I don't give a urine sample. And I just wonder if providing that pot from the GP or from the nurse at the practice might help?
I think definitely, as we recommend that at least one of those tests is from the first void, because
Okay.
we know that there are things that can impact on the results. So, you know, how much they've eaten in the day, how protein, whether they've done exercise, and so there's multiple factors that can impact that urine sample. So, yes, definitely giving a pot at the clinic and say, here, take this away. We go to the path lab and deliver would be ideal.
Yeah. Okay. Great.
Oh, sorry. Oh, sorry about that. My cat just totally jumped out of nowhere. Surprise visitor. Oh. The next question is about collection. So patients who don't complete first the void urine collection for the kidney health check, how can we ensure that it's collected?
I think we might have touched on that.
Yeah, I think so.
Giving the pots.
I was just wondering if, Claire, what do you think about providing 3 path forms at the beginning? And then, you know, maybe saying, like, if the first result was reviewed and it was like, oh, no, you don't need to do those, just, you know, toss them in the bin or something like that. Or, you know, like if the first result drops in and it's like, oh, yeah, I need you to do, you know, the second request form. Is that appropriate to, I'm just not sure, because I can see that, you know, if you did it in advance, it might be confusing. But then if you get a result and you need to do it again, perhaps, you know, logistically, you know, it's difficult. What do you think about that?
I think anything that can help with the collection in that time period. So again, it would be identifying the barriers. And I know for myself, if I had to go to visit my GP, they gave me results, you know, a form to have a test for something, and then they're like, oh, you need to do another one. I'd be like, why didn't you give me that when I was there?
Yeah.
So I do think that that could possibly be a way to combat that that issue. Again, you'd want to make sure that the patient understands that there needs to be time in between each test.
Yes.
And so you'd really want to make sure that the patient has that understanding of why and the time frames. So you wouldn't want to give it to someone who's a bit confused and doesn't really understand why.
So you could put a date on the slips, for example, because it needs to be at 3 months, really, doesn't it?
Yeah.
Yeah.
Very good ideas.
Yeah, great. How are we going, Mel? Any other questions?
No, that's it that's come in. So I want to thank everybody for being here with us today. It's a very interesting topic and very timely as well. Thank you all for being here. Really appreciate your time, and we'll catch up again with you all soon. Take care, everyone. Have a lovely afternoon. Thank you.
Thank you.
Thanks, Claire.
Bye.
Bye.
Bye.